Good morning. I want to welcome everybody back. It is my distinct pleasure to introduce to you Dr. Nathan Bryan. He's a PhD in molecular science and molecular cellular physiology. He went to Louisiana State for his PhD and was educated in the great state of Texas, undergraduate. Yeah, I knew. That would be big. I have had the pleasure of meeting this gentleman many years, coming to our conference where he introduced a product called Neo 40, Nitric Oxide. And if you do any cavitational surgeries or any kind of surgeries, implant placement, get your patient on a package. If they can't afford it, give it to them, because you'll see that they heal, and healing properly is a lot cheaper than trying to fix it later. And this clinical information that you'll get today is totally invaluable. And he has a very great way of presenting his information, and he's very approachable, along with Susan Schaefer in the back. Wave your hand. She'll be at their booth today. So without further delay, Dr. Nathan Bryan. Oh, by the way, if you call him Bryan, he also answers that too, because he's got two first names.
Well, I've got three first names. My middle name's Scott.
Oh, God, we're in trouble.
All right. Well, good morning. Thanks, Mike. It's really a great honor and pleasure to be here. I give about 40 to 50 lectures a year around the world, and these dental events are some of my favorite because you guys actually get it. Most of my talks to physicians, this is a new science for them, and the most difficult thing I've found in my 20 years of academic research is to re-educate physicians. And so my goal today is to introduce this whole field of nitric oxide. And it's relatively new. And as Mike mentioned, I have a number of disclosures that I'm obligated to reveal to you. I'm a founder and shareholder of a company called Human to the Power of N, where we've licensed all of my patents from the University of Texas Health Science Center in Houston. I'm also a shareholder and advisor for Sage Pharmaceuticals, and I receive royalties on these patents from the University of Texas. And so my objective is to, in the spirit of CME, I'm going to take you through the story of the discovery of nitric oxide, what discoveries we've made over the past 20 years, and have we been able to translate this into clinical medicine. And so when you do that, obviously there's a conflict of interest. If you create anything of value, hopefully you're going to create a conflict. So I started on this journey about 20 years ago. As Mike said, I received an undergraduate Bachelor of Science degree in biochemistry from University of Texas at Austin, and then went on and received a PhD from LSU School of Medicine in Shreveport in molecular and cellular physiology. So my focus since day one has been heart disease, because the statistics are staggering. So it's 1 in every 4 deaths. You can read the statistics here. Every 42 seconds, someone dies of a heart attack each minute, or someone has a heart attack each minute, someone dies. And to put this in perspective, this is the amount of people dying from, is equivalent to 4 jumbo jets crashing and killing everyone on board every single hour of every single day each year. So that should garner some attention. And so the fundamental question is, what in the hell causes heart disease? Is it cholesterol? No, we've been misled for 30 years in cholesterol. Cholesterol does not cause heart disease. Smoking, yes. Poor diet, yes. Poor oral hygiene, oral infections, absolutely. Sedentary lifestyle, inflammation, heavy metals. And so you ask your question, is there a common denominator in all these known risk factors for cardiovascular disease? And hopefully by the end of this talk, I will convince you with the published literature that nitric oxide is the common denominator in all of these. And really my objective in front of a dental audience is to bring you aware of the importance of what you do in terms of oral hygiene and these infections, and how this is affecting oral nitric oxide production, which then affects systemic blood pressure. And so most of these, what I'm going to show you, everything is published, although we learned this morning that only about 50% of the published literature may be accurate. I'd say that a lot of this has been reproduced in multiple peer-reviewed clinical or medical and scientific journals. So I want to start out, and really everybody has a patient that's very complicated that they can't seem to get well. And so, again, one of my objectives is to get you guys to thinking about nitric oxide as a potential, that loss of nitric oxide may be causal for a lot of their symptoms and may be presenting with. And so certainly anybody who's aging, anybody over the age of 40, because I'll show you some age-dependent trials that show you that the older you get, the less nitric oxide you make. Diabetics, I'll show you some published literature we published about 5 years ago showing the the role of nitric oxide in insulin signaling in type 2 diabetes. People with low energy, I don't have time to go through the details today, but nitric oxide controls and regulates mitochondrial ATP production, cellular energy. People with sexual dysfunction are those who just want improved performance in the bedroom, and who doesn't want that? Athletes wanting an improvement in performance, antacids, people on proton pump inhibitors, the third largest prescribed drugs worldwide, completely shut down nitric oxide production. And I'll take you through the mechanism of how that happens. Or I think, at least from my perspective, and the biggest effect we can have in public health is disease prevention. I think this field of the practice of medicine has to change from a reactive practice to a proactive practice. And so if I can teach you and bring you aware of some things that you can do, some simple lifestyle modifications to prevent this age-related loss in nitric oxide production. By the 150,000 published papers on nitric oxide, by all bets, we can prevent a lot of these age-related chronic diseases. So here's my objectives. One, give you kind of a working conversational understanding of nitric oxide, and introduce this concept of a human nitrogen cycle, and where the oral microbiome is critical in nitric oxide production. We know a lot about the gut microbiome. People haven't really focused that much on the oral microbiome, except in pathogens and trying to kill gingival plaque bacteria. But I'm going to introduce you to a new set of bacteria that we've identified that are commensal, non-pathogenic, but fundamental bacteria that can regulate systemic blood pressure. And then I'm going to take you through the translation of this into clinical medicine, and then I'll end with kind of putting the pieces of the puzzle together, because as an academician, I think we're taught in silos. I've studied a single molecule for the past 20 years, but forgetting all these metabolic pathways are interconnected like gears on a wheel. And so you can't affect one thing without affecting something downstream. And nitric oxide is not a silver bullet. It's not an end-all, be-all, cure-all. And so what I hope to do with this case report at the end is really bring in and integrate everything you've learned in your entire profession on fixing oral infections, good nutrition, and fixing the cardiovascular system in these patients. And I'll take you through a pretty complex case. But it's really very simple, and I've lived by this principle throughout my entire academic career, that a man is as old as his arteries. And we know from a number of studies that as we age, and this is obviously dependent upon diet and lifestyle, but even in post-mortem analysis of young kids who died in motor vehicle accidents, in their early teens, you can see fatty streaks already developing in the lining of the blood vessels. And then as we age, you get this plaque deposition under the endothelial cells in the intima, and then this plaque becomes unstable, and it's this unstable plaque that ruptures and causes heart attacks and strokes and leads to the statistics we saw earlier. We've also learned that through the development of these new novel biomarkers in peripheral blood, that the earliest stages of this whole cascade is inflammation. High sensitivity C-reactive protein, you start spilling protein in the urine. Later stages, you see an increase in myeloperoxidase, certain lipoprotein particles, and then diagnostic for acute MI is creatine kinase or troponin T. So our thought was, let's fix this here. If we can begin to detect these biomarkers here and then fix the inflammation, fix the immune dysfunction, and fix the oxidative stress, you can prevent this whole sequela of cardiovascular disease. We've also been able to mirror the nitric oxide production, and we call this endothelial function. So the older you get, the more dysfunctional your endothelium becomes, the less nitric oxide is made. So endothelial dysfunction precedes the structural changes in the vasculature by decades, many years, sometimes decades. So if you can begin to assess what the nitric oxide production is in your patients, then you can fix it, then you can prevent this whole sequela of vascular disease, the number one killer of men and women worldwide. So what causes arteries to age? Despite the infinite number of insults we give our body, whether it's focal infections or infected root canals or toxic metals, our body responds with three finite responses. And it's inflammation, immune dysfunction, and oxidative stress. And so if I can teach you how to really mitigate the inflammatory response, the immune dysfunction, and oxidative stress that results from any insult, whether it's an oral infection or whether it's all the standard cardiovascular risk factors, whether it's smoking, sedentary lifestyle, obesity, then you can fix the cardiovascular complications of these. And so we know that safe and effective nitric oxide restoration addresses these issues. So how do we prevent, slow down, or stop this progression. As I mentioned, it's nitric oxide. The challenge for us in academia for the past really 20 years is trying to develop a nitric oxide therapeutic, because this is a molecule, it's a gas that's produced by the lining of the blood vessels, and it's gone in less than a second. So it has a half-life of less than 1 second. So to recapitulate nitric oxide-based signaling through the development of drug therapy has been very challenging. In fact, most pharmaceutical companies at one time had a nitric oxide drug pipeline in their system, and so most have abandoned that now because we think nitric oxide is not druggable, meaning that most drugs are inhibitors of enzymes. Most, if not all, diseases are caused by an insufficient nitric oxide production. So it's not, you can't give an activator or a stimulator if you don't fix the enzyme. So to me, it was apparent many years ago that nitric oxide isn't druggable, but if you give the body what it needs, get rid of the toxins that are inhibiting nitric oxide production, then give the body what the body needs to make nitric oxide, then you can restore and recapitulate normal nitric oxide signaling. And we know it's involved in every biological function, from maintaining the structure and integrity of the cardiovascular system. It's the non-adrenergic, non-cholinergic mediator in the periphery. It's the requisite molecule for our own stem cells to mobilize and differentiate, to regenerate and repair tissue. It's a neurotransmitter in the central nervous system, controls cell cycle, sports performance, and it controls sexual function in both men and women. Erections in both men and women are caused by an increase in blood flow. The increase in blood flow is dependent upon nitric oxide production and vasodilation. If you can't make nitric oxide, you can't vasodilate, you can't get engorgement in the penis or the clitoris, and you become dysfunctional sexually. And we know the importance of nitric oxide because a Nobel Prize was awarded in 1998 to these 3 U.S. scientists, really for their discovery of nitric oxide in the cardiovascular system. And it was Fred Murad who discovered that drugs like nitroglycerin that were used for the treatment of acute angina for probably 200 years, he discovered that these drugs, so-called organic nitrates, work because they release nitric oxide, or they're metabolized into nitric oxide. Nitric oxide would dilate the coronary arteries, restore blood flow, and you get complete symptomatic relief of the ischemic pain. And then in 1980, Bob Furchgott discovered that our endothelial cells makes a substance that causes blood vessels to relax. And he didn't know what this was, but in his 1980 Nature paper, he termed this endothelium-derived relaxing factor, or EDRF. So for the next 7 years, the race was on to try to figure out what is EDRF, and then Lou Ignarro discovered that EDRF is nitric oxide. So if you give a nitric oxide donor, or you stimulate endogenous nitric oxide production, you can dilate blood vessels and control and regulate perfusion to all tissues throughout the body. Bob Furchgott passed away several years ago, but it was Farrad who recruited me to join the faculty of UT Medical School in Houston back in 2005, just south of here. I was at Boston University at the time, and so really a lot of the studies I'm going to show you was with Fred as my department chair, and then Lou Ignarro has written the foreword to several of my textbooks. And this was the front page of the New York Times the day the Nobel Prize was awarded by Val Fuster, that the discovery of nitric oxide and its function is one of the most important in the history of cardiovascular medicine. So the fundamental question we sat on about 20 years ago was, how do we control and regulate nitric oxide production? Because once we know how the body makes nitric oxide, we can begin to interrogate patients, sometimes in animal models of disease, figure out what goes wrong with enzymatic NO production, and then fix that, and then translate that back to humans. So in basic science, we're always told to go to bench to bedside. Well, that model doesn't work. What we've focused on is taking complex patients, going from bedside to bench, taking it to the lab, modeling it in model systems, whether it's experimental animals or cell culture or purified systems, and then taking it back to the bedside. So it's bedside to bench to bedside, that really how innovation occurs. And to make a long story short, and I'm going to take you through I'm probably going to tell you a lot more about nitric oxide biochemistry than you want to know, but if you get questions from your patients, I want you to have the information. So we now know that there are 2 ways the body makes nitric oxide. There's an oxidation of L-arginine through an enzyme called nitric oxide synthase, and then there's a nitrate, nitrite, nitric oxide pathway that's dependent upon both diet and oral bacteria. And so this is where it's going to become really relevant in terms of you guys. So each pathway provides about 50% of the total body nitric oxide production. So when one system fails, the other can compensate. When both systems fails, we get in trouble. So I'm going to show you how to fix both systems. And this is the complexity of what we deal with in terms of the oxidation of L-arginine. So as I mentioned, there's an enzyme called nitric oxide synthase. L-arginine is a semi-essential amino acid. And this enzyme takes this guanidino nitrogen and through a 5-electron multi-step oxidation generates nitric oxide. It's the most complicated and complex reaction in the human body. It's energetically and kinetically very unfavorable. It's the only enzyme known to require 8 different cofactors and substrates, from tetrahydrobiopterin, flavin-dependent cofactors, NADPH, glutathione, heme iron, oxygen. You can read that. And so when this enzyme becomes dysfunctional and uncoupled, it actually creates oxidative stress. So there's a disruption in the flow of electrons, and you reduce oxygen to superoxide. So this enzyme, when it becomes uncoupled, actually it causes a lot of oxidative stress. So how do you recouple this enzyme? Well, you do it through preventing the oxidation of tetrahydrobiopterin. And so we've also discovered years ago that you can extend the biological half-life of nitric oxide from 1 second out to tens of minutes and hours, because NO binds to the cysteine of glutathione. And then S-nitrosoglutathione actually has nitric oxide bioactivity. We've identified the enzyme that degrades this and some natural product inhibitors of this enzyme that we're developing as anti-airway inflammatory drugs in this company from Sage Pharma. I won't discuss any of that today. But what I will discuss and spend a lot of time on is when nitric oxide is produced, it's gone in less than a second because it reacts with oxyhemoglobin to form nitrate or reacts with molecular oxygen to form nitrite. And we've used these in the research lab for 20 or 30 years as oxidative metabolites of nitric oxide. But now we understand that we can metabolize these or reverse this and reform nitric oxide. So to summarize, L-arginine is controlled by the enzymatic function of nitric oxide synthase. I'll share with you some functional FDA-cleared devices that can give you an indication of that. And then dietary nitrate utilization is controlled not just by the amount of nitrate consumed, primarily through green leafy vegetables, but the oral flora. And so a lot of people will take or have taken, there's a lot of nitric oxide products on the market that contain arginine and citrulline, but you have to have a functional enzyme. There's not a single human disease except one, and I'll show you that at the end, that's caused by L-arginine deficiency. And so it doesn't make sense to give more L-arginine. In fact, if you have a dysfunctional NOS, nitric oxide synthase, giving L-arginine is like putting gas in a car with a blown-up engine. You're not out of fuel. The engine to convert that fuel is broken, so we have to fix the engine. The other consideration is arginine can activate a latent herpes virus, and at least 2 published trials, more on the way, that if you give high-dose L-arginine to sick patients that have endothelial dysfunction, they actually do worse. In fact, in the Vintage trial, these are post-infarct patients, the L-arginine group killed more people than the placebo. They stopped the trial halfway through. Same thing with patients in peripheral artery disease. These people have severe vascular dysfunction, and giving L-arginine actually made it worse. What about nitrate base? You see a lot of media around beets, and obviously we know that eating green leafy vegetables, the Mediterranean diet, is heart healthy, anti-cancer, but we know that all these aren't created equal. The amount of nitrate in vegetables and really nutrient assimilation depends upon soil conditions, the time of harvest, the amount of sunlight, the amount of rain, and then when you process this, you can destroy a lot of the nutrient density. And 2, if you don't have the right oral bacteria or patients are taking proton pump inhibitors, you can't utilize the nutrients from these foods. And I'll take you through mechanistically how that happens. But first, let me show you in normal, young, healthy people with good endothelial function how this enzyme was designed to work. So if you can appreciate that this is the lumen of a blood vessel, this would be the single layer of endothelial cells throughout the body. And then this is the smooth muscle that surrounds all blood vessels. So when smooth muscles contract, you decrease the lumen of the blood vessel and you increase pressure. If you dilate, or if these smooth muscles relax, you dilate, you increase blood flow through here and reduce pressure. So it's very simple hemodynamics. So when we begin to exercise, this causes shear stress in certain vascular beds, and that turns this enzyme on. And so this enzyme converts arginine to nitric oxide, and you get citrulline as a byproduct. And part of this NO diffuses into the lumen of the blood vessel where it interacts with platelets, monocytes, neutrophils, all these white cells that stick to the lining of the blood vessel. Nitric oxide prevents that. But part of it diffuses into this underlying smooth muscle where it activates this enzyme guanylyl cyclase. And it's this enzyme that Fred Murad had worked on that converts GTP to cyclic GMP. And this is responsible for smooth muscle relaxation. And some of you may be more familiar with this than you think, because this is the mechanism of action of Viagra, Cialis, and Levitra, the phosphodiesterase inhibitors. So these drugs actually prevent the breakdown of cyclic GMP. Interestingly enough, multi-billion-dollar-a-year drug, these drugs only work in 50% of the men in which they're prescribed. The non-responders are non-responders because they can't make enough nitric oxide here to activate this enzyme to lead to any accumulation of cyclic GMP. So this tells us that erectile dysfunction isn't a disease of overactive phosphodiesterase enzyme activity. It's a disease of nitric oxide insufficiency. And so our focus is on, well, how do we fix this here? Because if we fix this reaction here, everything else takes care of itself. And you can actually take non-responders to PD5 inhibitors and make them responders. And you can actually lower the dose of PD5 inhibitors and make them much more effective. Sedentary lifestyle. Obviously, if your ability to generate nitric oxide predicts how well you can perform as an athlete. To the contrary, these are older patients who have undergone an exercise stress test, and their inability to generate nitric oxide in their coronary arteries causes them to lose an exercise stress test. And all of these patients either were carted up to the cath lab and put stents in, or cracked open and done bypass surgery. So really, nitric oxide is the mechanism for the exercise stress test. If you can't dilate your coronary arteries to meet the increased metabolic demand of the heart, you fail the exercise stress test. So to control nitric oxide is critically important for perfusion of not just the coronary arteries, but all blood vessels throughout the body. And this is an average of 4 independent studies looking at this age-related production of nitric oxide. So what this clearly shows is that we lose about 10 to 12% of our nitric oxide production per decade. By the time we're 40 or 50 years old, we only have about 50% of the nitric oxide we had when we were younger. And I don't think it's coincidental that that's about the time people start to feel the effects of aging. You don't perform as well as you did on the athletic field. You don't perform as well as you did in the bedroom. In fact, 50% of the men over the age of 40 report some degree of erectile dysfunction. And then the older we get, the more compromised we become. And obviously, this is modifiable by diet and lifestyle. So our thought was, if we can prevent or at least delay this age-related decline in nitric oxide production, can we prevent age-related disease? And so I'm going to take you through some very basic science experiments that we did years ago. And the reason I show you this, and it's probably going to be more than you want to know, but this changed the way we thought about nitric oxide. There are certain catalysts in science that changed the paradigm. And so we asked very simple questions. I'm from Texas. We keep it very simple. And so the question we asked over 10 years ago was, if we increase nitric oxide production in the heart and we subject animals to a heart attack, can we protect the heart from infarct? And can we preserve the function of the heart after ischemia reperfusion? Obviously, this has huge economic burden. And then if we can protect the heart, is there some type of phenotype that we can trace biochemically that can give us new biomarkers for either prognostic or diagnostic? So this is how we do it. We take patients, obviously, with acute MI that have an occlusion for at least, hopefully, 60 minutes or less, bring them to the cath lab, reperfuse them. And so we mimic this in mice. And so in these transgenic mice, we overexpress the nitric oxide synthase enzyme only in cardiac myocytes. So these are transgenic mice. You can see the transfection is successful. They're generating nitric oxide because we can actually detect these oxidative metabolites. And if we subject these mice, so we do open heart surgery on these mice and tie a suture around the LAD, very high up around in the left anterior descending artery, and we keep that suture on for 45 minutes. And then after 45 minutes, we cut the suture and reperfuse for 24 hours. And in these mice that are overexpressing the nitric oxide synthase enzyme, they have very little infarct. In fact, it's indistinguishable from the sham-controlled. And so that told us that nitric oxide in the heart is actually very cardioprotective, even in the face of 45 minutes no-flow ischemia. The next thing we did was we looked at the blood of these mice, collected blood, and found, the nitrite-nitrate levels were elevated. Then we harvested the liver and found that the liver biochemistry looked exactly like that of the heart. This was a little bit shocking because nitric oxide can't survive the transit from the heart to the liver because of a half-life of less than 1 second. And to make sure it was a clean transfection, the liver hadn't all of a sudden started expressing more enzyme. So then we cut off the blood supply to the liver for 1 hour, then reperfused for 5 hours, and then measured liver enzymes as markers of injury. And you can see that there was the nitric oxide produced in the heart protected the liver from injury. We did these experiments back in 2005, 2006, and it took us 3 years to get this published in the Proceedings of the National Academy of Science. because this was the first demonstration that there was a hormone function of nitric oxide, or an endocrine function. Because prior to that, people thought nitric oxide could only act in the cell in which it was produced or a neighboring cell. So this was my aha moment in science, because this told us that if we needed to affect systemic nitric oxide production, all we had to do was generate nitric oxide in a single biological compartment. And keep in mind, the oral cavity is the most accessible, non-invasive biological compartment we have access to. So also understanding that in the atmospheric nitrogen cycle, we thought, well, can we use diet as a first-line therapy? Because we know that vegetables are grown in soil. The air we breathe is 78% nitrogen. This nitrogen is fixed into nitrite, nitrate, ammonia by lightning fixation or by microbes in the soil. So any vegetable that's grown in soil assimilates nitrogen and other nutrients, or any animals that we eat that eats the grass or the vegetables, that we're getting a dietary influx of this. We've also known, and this was made apparent probably about 12 years ago, that we have a human nitrogen cycle. So rather than nitrifying bacteria that live in the soil, they're denitrifying bacteria that live in and on our body. So we get most of our nitrate from our diet from green leafy vegetables. It's not, as we're taught in the media, that it's from eating hot dogs or bacon or nitrite-cured meats. Only 5% of our nitrate comes from cured and processed meats. 85% comes from eating green leafy vegetables, and the other 10% comes from swallowing our own saliva. So if nitrite and nitrate were cancerous, vegetarians would have a higher incidence of cancer than meat eaters. But it was known since 1978 that nitrate from green leafy vegetables, about 90 minutes after you consume vegetables, the nitrate is concentrated in our salivary glands. And this posed a little bit of a challenge to the cancer biologists at the time, because they thought nitrate-formed nitrosamines cause cancer. So why would our kidneys reabsorb nitrate and put it back in our salivary glands? Well, we discovered that there are oral nitrate-reducing bacteria that live on the crypts of the tongue that reduce nitrate to nitrite and nitric oxide. Humans don't have this enzyme, so they were 100% dependent upon oral bacteria. So this 2-electron reduction of nitrate to nitrite occurs in the oral cavity. When we swallow nitrite, a pKa of 3.4, meaning that it becomes protonated and generates nitric oxide. So as long as you have sufficient stomach acid production, you generate nitric oxide in the lumen of the stomach. Again, a single biological compartment where you're generating authentic nitric oxide gas that we can detect and quantify that will affect systemic nitric oxide production. If you take antiseptic mouthwash, if you take PPIs, you completely inhibit this pathway. And I'll show you the clinical consequences of that. So the fact that 50% or more of the nitric oxide is determined by foods and diets and oral bacteria really got us to focusing on, we knew how to fix the enzyme that makes nitric oxide, but if we could fix and standardize diets and standardize the oral microbiome, then we could really fix these pathways 100%. And this was at the time, this slide's probably 15 years old, but at the time, we knew that nitrate was important because you could lower blood pressure. By drinking beetroot juice, you can improve athletic performance. But this wasn't a foreign concept. The father of medicine himself, let food be thy medicine, medicine be thy food. And so we thought, well, what's the active component in these foods? For years people thought that the Mediterranean diet was because of all the antioxidants, the minerals, green leafy vegetables, the vitamin content, but no one's been able to recapitulate the effects of a diet by giving back these nutrients and vitamins. So what's missing? Something's missing. I would argue that nitrate, nobody ever controls for the nitrate in the diet. And this is just one study showing that if you take eNOS-deficient mice, so these are mice that cannot make nitric oxide, they develop type 2 insulin-resistant diabetes. This told us that loss of nitric oxide causes type 2 diabetes. And you got to remember, people typically don't die of diabetes, they die from the vascular complications of diabetes because of loss of nitric oxide. So if you give the eNOS knockout mice nitrate in their drinking water, you can see they gain less weight even though they're eating and drinking the same amount of food. Less visceral fat deposition, about 50% less visceral fat deposition, about a 25% reduction in triglycerides. Glucose tolerance improves, hemoglobin A1C drops by 50%, and the ratio of insulin to proinsulin reduces. And you get better management of blood pressure. And these are mice that have a genetic deficiency that they cannot make enzymatic nitric oxide production. So this pathway overcomes loss of nitric oxide. So that was an interesting observation, but it didn't tell us mechanistically what was going on. I'm a mechanism guy. And so the literature told us at the time that when insulin's secreted from the pancreas, it binds to these insulin receptors, primarily on adipocytes and liver and skeletal muscle, and then it initiates this signaling cascade. PA3, AKT kinase, AMP kinase, where metformin works, But all of these converge on this enzyme nitric oxide synthase. And the literature stopped there. No one knew what nitric oxide was doing from here to the terminal step of glucose uptake, to clear glucose from the circulation. So we designed some very simple experiments where we tagged the GLUT4 protein, the main transporter, to green fluorescent protein. So we could actually visualize GLUT4 translocation and glucose uptake in real time. And you may not be able to see it because the resolution is poor here, but you can just see that GLUT4 is normally a cytosolic protein, but when you activate it, it goes to the periphery. So you can see over time the cell membranes start to light up, showing GLUT4 translocation. And this correlates with an increase in glucose uptake. And we published this back in 2013, but mechanistically we figured this out, that there are 2 cysteine residues on GLUT4 that are conserved throughout evolution in any organism that uses glucose as a substrate. And so if you post-translationally modify these cysteine residues, that's necessary and sufficient for GLUT4 translocation and glucose uptake. So you can overcome insulin resistance simply by restoring normal nitric oxide production. So then the question was, how much nitrate do we need? We knew from the published literature that you need at least 300 to 400 milligrams in a bolus. We knew from estimation studies that the Western diet only gives us about 150 milligrams nitrate per day, and that's over 2 to 3 meals. So we become a nitrate-deficient society, and no wonder we're probably have the worst cardiovascular health. And I think mechanistically, if you look at a Mediterranean diet, that's providing about 800 to 1,000 milligrams of nitrate per day. The DASH diet, Dietary Approaches to Stop Hypertension, provides as much as 1,200 milligrams of nitrate per day. That's the reasons it's reducing blood pressure. So then we thought, well, are there foods out there that we can analyze, and how much celery would you need to eat? How much spinach would you need to eat? And so we did some very simple experiments. We analyzed over 30 different beetroot powders and actually organic beets off the shelf at Whole Foods, and find that there's as much as a 500-fold difference in the nitrate contents of beets. So my take-home message from here is, if you had a lot of products on the market now that have beetroot juice or beetroot extract, but we use a lot of these as our placebo in our clinical trials because it's a nice beetroot product, but it has no nitric oxide activity, has 0 nitrate in it. The next question was, again, going back to, if I wanted to affect your blood pressure, how much broccoli would you need to eat in a given setting? How much celery, spinach, lettuce? Could we quantify this and then change the dietary guidelines? And so to do this, I collaborated with some people at Texas A&M University, and we went to Raleigh, North Carolina, New York, Chicago, Dallas, and Los Angeles. We went to Whole Foods and bought the same vegetable off the same shelf, brought it back to the lab, and analyzed it for the nitrate content. And so it's probably too small to see, but our take-home message was that if you lived in Dallas, let's use celery for example, you could eat 8 stalks of celery as a bolus and get about 400 milligrams of nitrate, enough to lower your blood pressure. If you lived in Chicago, you'd have to eat 84 sticks of celery. So the regional differences in agronomy and the soil conditions completely determine the amount of nitrate in these vegetables. And these are conventionally grown. If we also measure organically grown vegetables to which there's no herbicides, pesticides added, but there's also no nitrogen added to the soil, the variability is even higher, and it's much less. So there's no way in hell we can ever make recommendations on how much celery you need to eat if you lived in, depends on which region you live in. And then the next step was, we knew that nitrate's inert in humans. So even if you are eating a good vegetarian diet, but you lack the right oral bacteria, you're never going to get a nitric oxide benefit from your diet. And that's apparent here, because if you take normal-tensive patients, and this is given chlorhexidine mouthwash twice a day for 7 days, blood pressure goes up. Now this drives cardiologists up the wall. You're telling me that if you eradicate oral bacteria, it affects systemic blood pressure? And 50% of the people that are prescribed antihypertensives are not managed. And I propose to you that the reason they're unmanaged is because these drugs are after the wrong target. There's no drug developed for affecting the oral microbiome, although I've submitted a number of patents on this because we think we can completely overcome resistant hypertension by restoration of these bugs. And so we began this project with the dental school in Houston, the UT Dental School, across the street from the medical school. And we started to try to interrogate these bacteria that live in and on our body. And the fact that these bacteria do something for human health is not that surprising. The human genome only has about 23,000 genes. The bacteria that live in and on our body provide about 3 million gene products. So they're there to do things that we as humans can't do. And so eradicating them is not always a good idea. So this is the denitrification cycle of bacteria. So if you recall, in the soil, there are nitrifying bacteria that take ammonia or nitrogen, and they fix this into nitric oxide, nitrite, nitrate that plants use as an energy source. The bacteria that live in and on our body do the opposite. They denitrify. So they take nitrate, 2 electron reduction to nitrite, 1 electron reduction to nitric oxide. So we got an IRB approved protocol where we started doing tongue scrapings across, and what we thought were normal healthy volunteers walking across the Texas Medical Center, see what in the hell they had growing in their mouth and what was it affected their blood pressure. We found out a lot of things. Number one, we found there wasn't a lot of people, healthy people walking around the Texas Medical Center, and they had a bunch of crap growing in their mouth. But the most interesting thing was that most of these people, we could detect nitric oxide production that then affected their systemic nitric oxide. And this is what we found. So you could see that these populations or these communities begin to aggregate based on good nitrate reducers, and in patients that couldn't reduce nitrate, they had completely different communities, oral communities. And through a full metagenomic analysis, again, we published this in 2014, there seemed to be about a dozen bacteria that correlated or were associated with good nitrate reduction. And then those that couldn't, there was completely different communities. Interestingly enough, lactobacillus in the mouth is really a bad thing for nitric oxide production. So lactobacillus in the gut we think is probably good. Lactobacillus in the mouth is bad, at least in our model systems. Then the next question was, and so we published that and then moved on to a more controlled study that we took people who we knew kind of these are mainly dental schools, dental faculty, some medical school faculty, who we thought had good oral hygiene. And these are normal intensive patients. And then we give them chlorhexidine once a day for 7 days and did tongue scrapings every day to see how this antiseptic affected the oral communities, and then how did it affect blood pressure. Very simple study. This was kind of the consort design. But what we found was that, and this is a single patient, that 7 days of chlorhexidine caused his blood pressure to go up 26 millimeters of mercury. This is a 21-year-old dental student that was young, healthy, normal intensive, and in 7 days we made him clinically hypertensive, simply by giving chlorhexidine. So then we did tongue scrapings and determined what bacteria disappeared at the time his blood pressure went up, what bacteria reappeared at the time his blood pressure went down. And then we did a metabogenomic analysis and found out what these bacteria were expressing. Were they expressing any enzymes that controlled nitric oxide production? So then based on that, we went back and had to modify the IRB to figure out what oral hygienic practices these people were using. Most people brush their teeth, which is still a good idea. I'm not saying you shouldn't brush your teeth. A lot of people use floss, mouthwash. Some people use mouthwash, and then some people clean their tongue. A lot of dental hygienist students who are obsessive compulsive about their oral hygiene. So then we sent the data back to the statistician and got this interesting data back. That if you scraped your tongue once or twice daily and you used chlorhexidine, this could predict your response to blood pressure. So there were 2 takeaways from here. Number one, if you cleaned your tongue, your blood pressure, starting blood pressure, was much lower. If you cleaned your tongue and used chlorhexidine, your blood pressure would increase much more dramatically than those who didn't clean their tongue. And so we're still trying to figure this out. We think maybe you're just opening up the pores on the dorsal part of the tongue, that the chlorhexidine has greater entry and more effective killing. The next thing we did was say, well, does this have anything to do with nitric oxide? So we started sequencing these gene products that these bacteria were expressing to figure out, does this have anything at all to do with nitric oxide? And this was kind of our money slide, because we could predict steady state blood pressure in 84 patients by the presence or absence and the number of these 4 bacteria. You know, in the dental community, I'm not a microbiologist and I'm not a dentist by any stretch of the imagination, but some of these, like Haemophilus, if you read the literature, it's associated with heart disease, and so I've filed a number of patents on these to repopulate these, because now we're finding in older resistant hypertensive patients, they don't have these bacteria. If you employ strategies to restore them, all of a sudden their blood pressure becomes normal without changing any pharmacotherapy. So obviously everybody in here has different oral microbiome. And so how do you overcome this variability? When I was a single man, I used to try to find a real pretty lady who I knew had the good nitrate-reducing bacteria and try to inoculate myself. So you can try to do that if you want, but there's better ways, I think. And so understanding that nitrate has to be reduced to nitrite by bacteria, what if we just give nitrite? And so this is a study, we basically did a dietary study in mice about 10 years ago. So we put them on a low nitrite-nitrate diet for 7 days. We could reduce their blood levels of these endometabolites. And then we gave back what was missing in the drinking water. And again, we subject these mice to ischemia reperfusion injury, occlude the LAD for 45 minutes. You can see the mice that don't have sufficient nitrite-nitrate in their diet have about 40% greater infarct in the heart. This is a significant injury. Typically, 90% of these mice will survive out to 24 hours, but 50% didn't survive out to 24 hours, and the 50% that did survive had 40% greater infarct. The mice that we gave the nitrite back to, 100% survived out to 24 hours, 30% less infarct. And if we do echo on these mice, post-infarct echocardiography was completely indistinguishable from the sham-controlled mice. So simply giving nitrite through the diet, independent of the bacterial nitrate reducers, we could protect the heart from injury. But then we started thinking backwards. Obviously, in patients that have heart attacks, it's plaque instability and rupture that causes this. And going back to one of the first slides, we know that the first stages of vascular disease is where monocytes, neutrophils, platelets begin to stick to the lining of the blood vessel. They migrate through, extravasate, they elicit an immune response, again, immune dysfunction. They become modified, oxidized LDL foam cells. Over time, this foam cell develops into plaque. Plaque becomes unstable, and we have this cycle. But it's also known that if you can inhibit this inflammatory response here, you can inhibit the whole sequela of vascular disease. So we did intravital microscopy, and this is real-time intravital microscopy of an atherogenic diet. And so you can see here there are a number of monocytes. This is 6 weeks of what we would call like a McDonald's diet. High carbohydrates, kind of a low protein, a lot of trans fats. You can see a roadblock here. There's a little bit of blood getting through here. A number of cells have already migrated through. So we can count these cells, the number that are stuck. We can count the cells that have migrated. And we published this back in, I think this was 2009. And so we give that same atherogenic diet, but we just throw a little bit of nitrite in the drinking water. And you can see the blood vessel is more dilated. The white cells home along the vascular endothelium looking for sites of injury. They don't stick and they don't migrate through. So you can completely inhibit the inflammatory response from a poor diet simply by restoring the function of normal nitric oxide production. What about genetic testing? I see I've got about 25 more minutes here, so I'm going to go quickly. And this is what I talk about. You know, I spent 20 years studying this reaction right here, forgetting about everything upstream. But if this pathway isn't working here, you get a buildup of these metabolites that affect other biochemical pathways. And so I show this here because the MTHFR has gotten a lot of attention. In fact, 30 to 40% of Caucasians may have an MTHFR defect. And people think it's just a methylation issue. But part of the activity of this enzyme is to reduce biopterin to tetrahydrobiopterin. So if you have an MTHFR SNP, then BH4 becomes limiting, and BH4 is the rate-limiting step in nitric oxide production. So by definition, MTHFR patients are nitric oxide deficient by this pathway. So how do you know if you're deficient in nitric oxide? There's really only one way to do it it's an old technique called venous occlusion plethysmography. And you can, through an ultrasound, you can put a blood pressure cuff on the brachial artery, increase it to suprasystolic levels, and occlude blood flow into the forearm for 5 minutes. And then you can get an ultrasound, and when you release the cuff, a normal physiological response is called reactive hyperemia. You get a dilation of the downstream blood vessels. And this dilation is dependent upon nitric oxide production. So if you get resulting vasodilation, then this tells you have good endothelial function. The enzyme can make nitric oxide. If you don't get dilation from from releasing the blood pressure cuff, you have endothelial dysfunction. You can't make nitric oxide. There's some newer devices on. I just show this one. This is a company in Houston, but this is again blood pressure cuff for 5 minutes. They put a fingertip probe, temperature probe on the index finger, and the rate at which you restore temperature to the fingertip correlates with nitric oxide production. And so you can see here, this is mine. I have really good endothelial function. If I didn't, I wouldn't show you this because you wouldn't believe it. We also knew that as you increase your cardiovascular risk load, you decrease your nitric oxide production. So whether you smoke, hyperlipidemia, hypertension, age, all leads to a stepwise reduction in nitric oxide. So I developed a novel salivary test strip that you could spit on, and basically it's a proxy for salivary nitrite. So if you have endothelial dysfunction, you can't make nitric oxide, you have a decreased nitrate. If you don't eat a good diet enriched in nitrate, you have reduced nitrate. If you have reduced nitrate, You have less to reduce to nitrite, so the nitrite's low. If you eat sufficient nitrate in your diet, but you don't have the right oral bacteria, you don't get any nitrite produced, you become low. So we've been able to use this as a semi-quantitative colorimetric test here. So these are available on the market, but it really gives you a good sense of your nitric oxide production. There are false positives. So when I see this all the time where you get some really sick patients come in, but they light up this test strip. And so if you have an active oral infection, you elicit an immune response in the oral cavity, and these macrophages, neutrophils, and monocytes generate a lot of nitric oxide, so you'll light up this test strip. So if they're physical exam and they're hypertensive and show all the signs and symptoms of nitric oxide deficiency, but they're high on the test strip, it's typically an active oral infection. So I'm going to switch gears and just take you through really about 17 years of work of how we've been able to take these learnings from basic science and translate it into something that healthcare practitioners can use in their patients and overcome whatever problem it is, whether it's a genetic deficiency or just poor diet, poor lifestyle. And again, I remind you that, again, Linus Pauling says that most diseases can be traced to nutritional deficiency. I would argue that it's either caused by some toxin in the body that's disrupting normal biochemistry or some nutrient that's lacking for normal metabolic activity. So if you remove the toxin, restore nutrition, good things happen. So this kind of summarizes it here. To make a long story short, we know that we can get nitrate from beets, kales, from our diet. We know which bacteria are responsible for reducing it to nitrite. We published a Nature paper back in 2005 showing that nitrite reduction along the arteriovenous circulation or oxygen gradient is really inefficient. So I discovered some natural product chemistry that really increases nitrite reduction from 0.01% to about 90%. And that's the basis for my dozen or more issued U.S. and international patents now. So to make a long story short, we know how to make nitric oxide, both from L-arginine, restore the function of this enzyme, and then basically create a system that we can recapitulate nitric oxide-based signaling on the arterial side, through the capillaries, and even on the venous side of the circulation, through the entire oxygen gradient. And so these are all published trials, so you can see that we've generated some natural product chemistry, and this is we designed this to be an orally disintegrating tablet. Again, going back that we could control the metabolic fate of NO in the oral cavity. It's not a pill you can swallow because depending on if you're taking proton pump inhibitors, or if you have H. pylori overgrowth, or you've just eaten, the contents of the stomach would determine nitric oxide production. So we generate an orally disintegrating tablet that generates about 30 parts per million NO gas in the oral cavity for 4 to 5 minutes as it's dissolving. And for those of you who don't know, this is the same amount of nitric oxide that's given in the pediatric intensive care unit for premature babies with pulmonary hypertension, or even in the adult cath lab for pulmonary hypertension or even cardio bypass surgery. You see we get peak plasma concentrations within 20 minutes. There are over 400 risk factors for CVD, and I'm just going to show you a few of them, but now we're collecting data that most, if not all, of these can be affected by restoring NO production. This is a double-blind, placebo-controlled crossover study, the gold standard in clinical trial design. And we're basically looking to see if we could affect normal nitric oxide production in people that had compromised NO production. So we get baseline blood pressure, ultrasound of the carotid, pulse wave analysis, and then normal endothelial function. Give one administration, 10 minutes later look at ultrasound, 20 and 60 minutes later look at blood pressure, 30 minutes look at pulse wave analysis, and 4 hours later, long after that NO is gone from the oral cavity, did we fix the enzyme in the lining of the blood vessels. Allow a 3-week washout, cross the patients over, and then re-administer. And these are the data here. So you can see that we could statistically significantly reduce the both systolic and diastolic blood pressures at 20 and 60 minutes. 4 hours later, we see a 15% improvement in endothelial nitric oxide production, showing that the acute NO release dilates blood vessels, reduces pressure, and restores the function of the enzyme that makes nitric oxide. So really improving the body's own ability to make nitric oxide. This is the left common carotid, an ultrasound at the level of the bifurcation. You can see internal luminal diameter of 0.52 centimeters. 10 minutes later, we've dilated to 0.6. So if you use simple laws of hemodynamics, this 13% increase in diameter causes a 34% increase in blood flow. We're seeing an improvement in cognition in patients with vascular dementia, which the functional MRI study shows that it's really hypoxic prefrontal cortex. If you restore blood flow to the prefrontal cortex through enhancing nitric oxide, cognition improves. What about pulse wave analysis? You can see central aortic pressure, so not only systemic pressures go down, but central aortic pressures, which are more prognostic for adverse events, improves. Small improvement in cardiac output. Total vascular resistance improves, and this augmentation index, which basically measures arterial stiffness, improves by 60% within 30 minutes. So this is pulse wave analysis showing with each beat of the heart, if you've got stiff arteries, this pulse travels real fast down the vascular bed. If you've got compliant, flexible arteries, it dampens the pulse wave with each beat of the heart. You want compliant, flexible arteries. So then what about prehypertension? And this is a condition where patients have a blood pressure between 120 and 139 systolic and 80 and 89 diastolic, to which there's no standard medical therapy. They tell you to reduce your sodium intake, change your diet, start exercising, but who in the hell does that? So 6 months later, 95% of these prehypertensive patients become hypertensive and then candidates for drug therapy. So we thought maybe this is just a nitric oxide problem. Can we reverse that trend? And this was published several years ago from a study with Cedars-Sinai. 37 patients that were prehypertensive, we made 100% of them normotensive in 30 days. To the tune of 12 millimeter reduction in systolic, 6 millimeter reduction diastolic after 30 days. So again, prehypertensive patients made them all normotensive. 6-minute walk test improved, showing an improvement in the functional capacity of the heart and vascular system. And then a quality of life questionnaire, there was a significant improvement in quality of life outcomes as measured by this SF-36. So let me end with a couple of really important and really life-changing case reports that I was involved in. So working in the Texas Medical Center is really a special place because you get to collaborate with some of the brightest minds and physicians in medicine. I'm a basic scientist. I'm not involved in patient care at all, but I'm pulled into these complex cases because we can now model these complex disease in model systems. So there's a group of patients that have an inborn error in metabolism, a disease called arganosuccinic aciduria, or ASA for short. And so these people are born without an enzyme called arganosuccinate lyase. And if you remember back from basic biochemistry, this is a urea cycle enzyme that helps dispose of urea. So if you don't have this enzyme, you get a buildup of arganosuccinic acid. It's excreted in the urine, and that's the basis for the diagnosis. Now there's newborn screening that can pick these up actually in utero. And so these patients develop a lot of symptoms. Their primary problem is hyperammonemia. But as this is controlled with drug therapy and diet, they're still developing progressive liver dysfunction and cirrhosis, blood clotting disorders, neurological dysfunction that appears to be independent of their current hyperammonemia, resistant hypertension, renal dysfunction. And so these kids they'll typically die at 7 or 8 years of age unless they get a liver transplant. And so we were called in to try to figure this out. And so again, we took these patients, we modeled it in mouse systems, and created a mouse model that didn't have this arganosuccinate lyase. And through a series of discovery, we published this in Nature Medicine in 2011. We discovered a new protein complex that controls nitric oxide production. So this tells us a lot of things. It tells us that the enzyme nitric oxide synthase doesn't use extracellular L-arginine to make nitric oxide. It uses arginine that comes from citrulline through this partial urea cycle. And you've got this beautiful intramolecular shuttling of substrate to make nitric oxide. So this enzyme makes nitric oxide. You get citrulline as a byproduct. These enzymes reconvert it to arginine. Arginine shuttled through the nitric oxide pathway to make nitric oxide. So without this enzyme, this protein complex falls apart, and these people become nitric oxide deficient. So this is really the best human model for nitric oxide deficiency. So the question was, can we overcome this deficit? And the answer is yes. So this is the lifelong blood pressure profile of this one pediatric patient. You can see at 5 years of age, he was put on standard pharmacotherapy. For 10 years, his blood pressure was really poorly managed. In February of 2010, he presented at Texas Children's Hospital with blood pressure of 185 over 135, a 15-year-old kid in the pediatric intensive care unit. We knew at that time that it was a nitric oxide problem. So they started giving him isosorbide or organic nitrate. Within 4 days, he was released, and he did quite well for a number of months. And then he developed tolerance, or this tachyphylaxis to organic nitrates. And he came back almost a year to the date, February of 2011. He was taking 20 milligrams ISDN 4 times a day, and his blood pressure was 180 over 115 when we saw him. We gave him our nitric oxide therapy. Within 4 hours, his blood pressure was 135 over 80. And we're 5 years out. We published this in the American Journal of Human Genetics back in 2012. But now we're, I think, 5 to 6 years out. The kid's graduated high school. He's off all prescription medication. His blood pressure's improved. We've got 2 ongoing NIH-funded studies to look at both the neurological endpoints in these rare patients as well as the cardiovascular endpoints. Here's an important change here. This 15-year-old kid had left ventricular hypertrophy, heart twice the size of a normal 15-year-old. Within 5 months, you can see here that all of his left ventricular hypertrophy completely remodeled. It had normal cardiac function, normal cardiac through echo. And we also increased the number of circulating endothelial progenitor cells here. So by restoring nitric oxide production, we stimulate the young kid's stem cells to completely restore and regenerate dysfunctional tissue. This kid here was taken for a day, a 15-year-old kid, probably weighed about 115, 120 pounds. And so the physicians monitored him for 4 days, and I basically taught the parents to dose him based on the blood pressure. And so this gave us a number of insights, too, that this is extremely safe in the forms of, I wouldn't say take 10 at a time, but at least 1 lozenge every 6 to 8 hours seems to be safe and very effective in managing blood pressure. This is a case report published last year where we took people with some carotid and some immediate thickness, and 6 months of taking the nitric oxide twice a day, we see 11% plaque regression. If you compare this to the meta-analysis on statin therapy, aggressive statin therapy, that gets cholesterol and LDL in the basement, you see a 2.7% regression of plaque in 3 years. We see 11% regression in 6 months. So what are the safety considerations? Obviously, I was in the drug discovery program. I went to the FDA back in 2006 and told them we know how to make nitric oxide. How do we bring this to market? And so safety first. So we had to do some safety studies. The acute toxicity of both nitrite and nitric oxide is methemoglobinemia and hypotension. And the fatal dose of this, you need about 2 grams in humans. So the FDA's guideline is if you don't have any really standard guidelines, then go 100 times less than the LD50 in animals. The other problem is this long-term propensity to form nitrosamines. You can prevent that through nitrosative chemistry. And so our approach for the past 15 years has been, let's give the body what it needs to make nitric oxide. And this is no different than vitamin D or magnesium. Unfortunately, there's no labs to tell you what nitric oxide is. So if you're low in vitamin D, what do? You give your patients vitamin D. If they're low in magnesium, you give them magnesium. And so to restore normal nitric oxide production, we had to know how much nitric oxide does a normal healthy person make. And so we did some basic stoichiometric conversions and found that the human body makes about 20 to 40 milligrams of nitrite per day from NO oxidation, from nitrate reduction from the diet, and from swallowing our own saliva. So that gave us some guidelines both on safety and restorative therapy for giving the body what it's missing. So let me just show you, obviously I've shown you a lot of data, but there's things that can go wrong. So number one, we don't eat enough green leafy vegetables, or we could be eating green leafy vegetables and they have no damn nitrate in them if you live in New York or Chicago. Insufficient saliva production, people with Sjogren's syndrome or cancer patients undergoing a parotidectomy. Using mouthwash, I tell people, get rid of your mouthwash. It's better to have bad breath than to have a heart attack. PPIs, really bad idea, and you got to control the oxidative stress. Let me take you through a couple of more really population-based studies, because the next question we had to ask ourselves is this what nature intended? I'm a biochemist and physiologist by training. You don't want to do anything to disrupt nature. So we asked ourselves, what's the consequences of adequate NO production? Are there patient populations out there that become completely devoid of any nitric oxide? What do those patients look like? And do they exist? We found the answer in Tibet. We were working with an anthropologist who was studying the chronic adaptive effects of people living at high altitude. So people that live in Tibet is 12,000 feet above sea level. These people are the Sherpas that lead people up to the top of Mount Everest. They don't get acute mountain sickness. They don't get high altitude pulmonary edema. So how do they adapt to this low oxygen environment? And this is the data here. So even though they're breathing less oxygen, obviously because the partial pressure of oxygen is lower, they're delivering more oxygen per unit time than people living in sea level. So they sent us the samples and say, well, how are they doing this? Obviously, I'm showing you this. It's nitric oxide related. So this is nitric oxide bound to hemoglobin in these Tibetans, where people living in the U.S. at normal atmospheric pressure, but they have a lot more nitric oxide. In fact, plasma levels of nitrite and nitrate that are 50 to 100 times higher than people living at sea level. We've been able to reproduce this in Ethiopia, which is about 6,000 feet above sea level. People in Ethiopia have intermediate nitrite levels of people living in the U.S. or Tibet. We've also been able to recapitulate this in well-trained athletes. You take them to altitude, people think that altitude training is simply erythropoietin and increasing hemoglobin concentration. But it's not. You can take people to altitude at 5,000 feet for a week, they increase their nitric oxide production. You take them to 10,000 feet, they further increase their nitric oxide production. These are young, healthy people. The problem is if you can't increase your nitric oxide production, you'll get acute mountain sickness. And that's why older people who go to the high altitude develop high-altitude pulmonary edema. And so you can basically correct for this and adapt people who aren't normally able to adapt by restoring their nitric oxide. The other end of the spectrum are hemodialysis patients. And this came from a nephrology buddy of mine who had been dialyzing patients for 40 years. And he goes, even though I correct for all their risk factors, lower their blood pressure, lower their cholesterol, they still have a 5-year, 70% mortality. These people die mainly of cardiovascular-related events. And so I actually asked a very simple question. We got an IRB-approved protocol, and I go, what is hemodialysis doing to nitric oxide? So we brought these patients in. These patients get dialyzed every 48 hours. So we take blood from their fistula as they're coming in. We take blood coming out of the machine after one pass. And then 4 to 5 hours later, we take blood again from the fistula. So new steady-state levels. So the hemodialysis is removing about 60 to 80% of plasma levels of nitrate. We do endothelial function tests on these patients. They have no endothelial function whatsoever. And to my surprise, these people are eating pimento cheese sandwiches and potato chips while they're being dialyzed. So there's not getting anything from their diet. And if we measure their saliva, you remove about 95% of their salivary nitrate. So no wonder these patients are dying because they can't make nitric oxide. The process they're undergoing every 48 hours is removing what little nitric oxide they have. They die of heart attack or stroke. The next answer came in this little guy here. This is my 9-year-old. He won the Super Bowl last year in his football league. But 9 years ago, my wife we were leaving the hospital. She had just given birth to this little guy, and the milk was having trouble coming in. And the discharge nurse said, well, here, take this formula, and if the milk doesn't come in, then give this baby some formula. And I knew the disparities between breastfed and formula-fed babies, and I didn't want to give my kid any formula. So I convinced my wife when I was leaving the hospital to come to my lab and give me some of that precious breast milk. And after a bit of a fight, I convinced her. But I just basically analyzed it for nitrite and found that the breast milk, this was colostrum, was enriched in nitrite. It was absent in the formula by design. And then I went to Methodist and got an IRB-approved protocol to go in, and we measured 75 mothers expressing milk at different days postpartum. And this was a little bit kind of freakish for me because I got a lot of no's. You got this guy coming in, it's the most happiest moment of the time, and I'm in there trying to get 1 cc of breast milk. But I got a lot of data from this, and so again, we published this several years ago, but this is how exquisitely designed nature is. That we got to remember, babies are born sterile. They have no nitrate-reducing bacteria. So through the milk letdown reflex that's dependent upon nitric oxide, we're providing nitrite in the colostrum in this early transition milk. But as the gut and the oral cavity begin to be colonized about 1 week to 2 weeks in, then the breast milk switches from primarily nitrite to nitrate because the bacteria are there to reduce the nitrate to nitrite. The other thing, and I don't have time to show you because I'm going to go through here, but we did some studies at Texas Children's Hospital for necrotizing enterocolitis. These are preborn babies born. They're not breastfed. They're given formula milk because they're in an oxygen incubator. They develop necrotizing enterocolitis, still about a 20% mortality. We can completely overcome NEC by giving nitrite in their formula because these babies don't have the right oral bacteria and they're not getting the nourishment that they need from their diet. So let me just conclude that I think I argued now for probably about a decade that we've discovered really some new vitamins. And if you look at the definition of vitamins, it's any group of substances found in small quantities to normal metabolism, found in minute amounts in foodstuff, and deficiencies produce sufficient disorders. So it may be more than just scurvy from lack of vitamin C or beriberi from lack of B vitamins. But could it be that if one does not eat sufficient foods rich in nitrate or have the right oral bacteria, that cardiovascular disease develops, the number one killer of men and women worldwide? But I think at the very least, we should be viewing these as indispensable nutrients. And this is what Lou Ignardo said in one of the forwards to one of my textbooks, that we may have an explanation for the mechanism of a Mediterranean diet or the link between oral health and systemic disease. I published on this to try to provide guidelines, nutrient guidelines, because we have a very big U-shaped curve here. We know that we can establish guidelines here that too little is bad, but you can also develop too much bad and develop methemoglobinemia and hypotension. But there's 100-fold difference between the recommended daily allowance and upper limits that we could establish. So let me just end you, beware of pretenders. There's a lot of people out there saying they know how to make nitric oxide. I've been doing this for 20 years. There's certain things you have to do. And because if you don't know what you're doing, I published this in 2004, over 13 years ago, because we were interested in trying to figure out, if you make nitric oxide, where does it go? The nitric oxide itself is gone, but where does it go? What does it become? If you don't know what you're doing, it can react with superoxide to form peroxynitrite, form these potent nitrosating agents, NO2, nitrogen dioxide, and form these nitrosamines. And so you have to be able to mitigate the metabolic fate or determine the metabolic fate of nitric oxide. And a lot of people don't know what in the hell they're doing. So what about case reports? Let me show you one last study, and then I'll close it and we'll go to lunch. But again, going back to nitric oxide is critically important. But if you've got people who are burdened with toxic metals, then the nitric oxide is never going to have an effect, because metals will scavenge any nitric oxide that's produced. And so this came from really a very near and dear to my heart. This is my dad, who's been in a wheelchair since 1984 from a car accident. So a T11 injury here. He had, for years, he had to defecate the digital stimulation. And so he had hemorrhoidectomy surgery about 5 years ago, and the surgeon did a very poor job on the surgery. So he told him to go home. My dad was overweight, diabetic, hypertensive, and said sit on a heating pad for 30 minutes at a time, 3 times a day, to facilitate wound healing. And this is the results of a heating pad from 30 minutes of paraplegic. Obviously, he didn't feel this because of the T11 injury. And so this was a very dire situation. And so we took him to Brooke Army Medical Center, and they basically did a graft, did a colostomy because of to try to divert the bugs. But they basically said he wouldn't probably survive from this. And if he did, the graft would take probably about 6 to 9 months to heal, if it ever healed. So I developed some gauze, and I would train the nurses to use this at night, and within 3 months, we completely closed that burn. The surgeons at Brooke Army Medical Center had never seen anything like this before. And that's simply just creating a gauze over the wound that generates nitric oxide gas. We're now developing these into internal beds and for surgical site infections that you can generate nitric oxide. But we thought we had a win there, but the problem was when they grafted over it, he had a festering decubitus ulcer, a pressure ulcer over his right ischium. I could fit a softball inside this cavern here. You can't really see it. So for 4 years, we battled this wound. The best wound care docs in Texas and the U.S. told me I could never heal this wound. My dad had several silver caps, gold caps. He had 6 root canals. He was unhealthy from his diet, so I took him to Stuart Nunley in Marble Falls. We got his teeth cleaned up. We removed all the oral infections, all the mercury amalgam fillings, started giving him good nutrition, and within 6 months, the wound was 95% healed. For the previous 4 years, we were getting nowhere until we put the pieces of the puzzle together, removed the toxins, restored normal health, and the body heals itself. It's a remarkable organ system. So let me just conclude here with, hopefully I've convinced you that nitric oxide is important. You can get this dietary, nutritional strategies, but again, you have to remove any toxins or hurdles in how nitric oxide is made. And healing begins in the mouth, and dentists are the most important healthcare practitioners on earth. So the take-home message is nitric oxide production is complex and complicated. Beware of pretenders. Look for products backed by science, patents, and clinical trials. And I think the evidence is clear that your patients will not get better until you restore their nitric oxide production pathways. So there's still some unanswered questions, and this is where I hope to collaborate with you guys, because the questions still remain. Can NO kill oral pathogens? And I know there's these oral DNA and oral pathogen labs that you guys can do, and so we want to understand what the nitric oxide produced in the mouth is doing to oral pathogens that you guys try to eradicate. Do these pathogens disrupt nitrate reducers? We're gathering some evidence now at the dental school that these gingival plaque-causing bacteria actually disrupt the nitrate reducers. We think it's a competition for limited resources, and these pathogens actually outcompete the other communities and basically out-survive them. And then what types of oral hygienic practices can facilitate NO production? In all these studies, we use chlorhexidine. We're starting to use things like Listerine and alcohol-based mouthwashes, and it's not as effective, but you're still disrupting nitric oxide production. But we don't know what oil pulling, for example, does, or certain oils or other hygienic practices do to facilitate nitric oxide production. So if you want to get published, I'm happy to collaborate. I'm just down the street here at Baylor College of Medicine. We've got a number of studies ongoing, and so I welcome any feedback you have. And again, I just remind you that all truths pass through 3 stages, and these are fundamental truths that we've discovered. First, it's ridiculed. Second, it's violently opposed. And third, it's accepted as being self-evident. I think we're in Schopenhauer's second stage here because this is violently opposed. I've done a lot of consulting for most pharmaceutical companies over the past 20 years, and they do not like anything we're doing anymore. And I've certainly been ridiculed by my academic colleagues. And so I just leave you with one last reference here. This is a book I edited with Joe Lascalzo, who's chair of medicine at Harvard Medical School and chief of cardiology at the Brigham. We're in our second edition here, but we have 21 experts where we talk about really this whole field. And we talk about nutritional epidemiology. Walt Willett at Harvard wrote the chapter on that. We talk about cancer biology. What is the cancer risk? We talk about hypertension, exercise performance, all these things, really the past 30 years of nitric oxide science concentrated in a single book. And so with that, I'll be happy to answer any questions. And this is my Baylor College of Medicine email if you have questions after the fact. And so thank you very much for your attention. Yes, ma'am. We've tried that. Have you tried seeding the oral bacteria to do that? So I filed a number of patents on this and then went to the FDA to see if we could actually do that experiment to get an IRB-approved protocol. And because there's no long-term safety trials on these bacteria, they won't allow us to do these experiments. Even though they're oral non-commensal or commensal non-pathogens, it's laughable. Yeah, but we think it may be. We're finding now, and we published this in rats several years ago, but if you just give rats nitrate in their drinking water, that the oral microbiome changes. And I think the explanation for that is that these are nitrate reducers. These are facultative anaerobes. And so when they run out of oxygen, they start respiring on nitrogen. But if they don't have enough nitrate in the saliva or in the crypts of the tongue, they can't flourish. But if you just give them, so if you start eating more vegetables, and we know changes in diet changes the gut flora, changes in diet changes the oral flora. So it may be that simple.
For those of you that are interested in working with some research, Dr. Bryan has been very generous about making an offer to the IABDM. If you want to talk to him about that sometime this weekend, if you've never been published before and kind of like to branch out and do that, then please talk to him about that.
It's a good point. Yeah, we're starting to get, and really with Stuart Nunley, to do these gingival scrapes and look under a light microscope and see these spirochetes and all these bad things that happen. And I think patients like to see that because they're seeing is believing. And then we're finding that if you give the nitric oxide, you can see a lot of these pathogens, at least under light microscope, go away. But that's what we're, at least from the light microscopy data, but I'm interested in more of the DNA analysis and seeing, because you guys know certainly better than I do on what are relevant pathogens that you guys look for and try to eradicate. And I think this whole broad approach of using chlorhexidine to eradicate all bacteria is not the way to go.